COPD or chronic obstructive pulmonary disease, or we can say chronic obstructive lung disease, cold. It is characterized by persistent respiratory systems and airflow obstruction. In fact, airflow obstruction is a physiological marker for COPD. So it's an obstructive lung disease, as its name suggests that there will be obstruction of the airways. And whenever there is obstruction of the airways, main problem is in expiration. So that is why in COPD also main problem is in expiration. And this airflow obstruction, it is measured by spirometry. In fact, there is a gold criteria by which we measure the severity of this COPD that we will see. Now this airflow obstruction, there will be some airflow obstruction and it will be precipitated, or there will be exacerbations in presence of noxious environment. For example, in case of smoking, which provides noxious environment for the airways and the lungs, environmental pollution, then certain occupations, there will be noxious environment. So that will precipitate this airflow obstruction. Now, though I am talking about airflow obstruction, you will think about the airways, but this disease is limited to mainly the respiratory passages where the gas exchange is taking place. So that is starting from the respiratory bronchioles, that is beyond the terminal bronchioles, respiratory bronchioles, alveolar ducts and alveoli. Right, so that is where the gas exchange takes place. So you see that this disease includes emphysema, then there is chronic bronchitis, and then there is a small airway disease. Okay, so this emphysema and small airway disease, it is like in the respiratory gas exchange region, and chronic bronchitis involves the bronchus as well. So in emphysema, how do we define emphysema? Emphysema is defined anatomically, in which there is destruction of the walls. Okay, so here you see there will be septa, right, and these septa will be destroyed. Actually, if we see that this is the respiratory bronchiole region and there will be alveolar ducts and alveoli, so all the septa will be destroyed and this will become as one single mass, right? So this is known as emphysema, where is destruction of the alveolar septa, and this decreases the surface area for gas exchange. One is that decreases surface area for gas exchange. Second thing it does, that there is a decrease in the recoil of the lungs. So if there is decrease in the recoil of the lungs, what is going to happen? Recoil generates the pressure within the alveoli so that the air is going to move out. So that will not happen. So there will be decrease in expiration, and also there will be hyperinflation of the lungs. So much more lung volumes will be there, right? So air will be trapped in the respiratory passages. So that is known as hyperinflation. So that is emphysema. Coming to chronic bronchitis, it is defined clinically. Emphysema is defined anatomically, and that also is seen in chest x-rays also. Chronic bronchitis, on the other hand, is defined clinically, and that is the presence of chronic cough with sputum for 3 consecutive months in 2 years. Okay, so in the last 2 years, for 3 consecutive months, if he had chronic cough with sputum, then it is known as presence of chronic bronchitis. So in chronic bronchitis, the bronchus, there will be inflammation. We will see the pathological part of it. There will be inflammation in the bronchus, and there will be other changes as well. Then we have the small airway disease, in which small bronchioles are affected, and small bronchioles, there will be narrowing of these small bronchioles due to hyperplasia and fibrosis. So there will be enlargement of the cells and fibrosis is going to take place because there is chronic inflammation, as there is noxious environment. Mainly this COPD affects the smokers, or to persons who are consistently exposed to environmental pollution and they are in certain occupations in which they are inhaling certain dust. Say suppose they are a tailor, they are exposed to cotton, textile dust is there. So in that case there is chronic inflammation in the airways, and this leads to hyperplasia and also fibrosis. So in this case there is a small bronchiole narrowing and there is decrease in number of these airways also. So that is chronic obstructive pulmonary disease, includes emphysema, chronic bronchitis and a small airway disease. In fact, this small airway destruction is the hallmark of COPD. Now let us see what is pathogenesis of COPD. As I have been telling that there is chronic inflammation, and I talked about certain risk factors also. So pathogenesis basically involve cigarette smoking, which is the most actually proven factor for COPD. Then there is elastase, anti-elastase hypothesis, which is responsible for the genetic predisposition of COPD. And third is oxidative stress. And oxidative stress, basically it is always there, but it works more in presence of cigarette smoke or because of this problem in this elastase anti-elastase balance. So what does the cigarette smoke do? That when the person smokes chronically, there is exposure of the airways and the alveoli to the smoke, and this leads to macrophage and epithelial cell activation within the airways and in the alveoli. So there is macrophage activation, and also there is CD8 plus T cell recruitment. CD8 T cells are recruited and they secrete certain chemicals which cause macrophage activation as well. Now these macrophages release a protein, matrix metalloproteinases. So these are proteinases. So these proteinases break down the extracellular matrix, and whenever there is breakdown of extracellular matrix, the cells which are in contact with that, they also die. See, there is always a dialogue between the cells and the extracellular matrix. So if the supporting extracellular matrix is destroyed, the cell ultimately die. Okay. So what is happening? This damage to the extracellular matrix is basically destroying the elastin. Elastin is the supporting connective tissue present in the lungs. So if that is destroyed, what is that? That is destruction of the septa which I was talking, and this will make the whole respiratory region where the gas exchange is taking place into one unit. So that is development of emphysema, right? Second thing is elastase anti-elastase hypothesis. Basically, due to exposure to cigarette smoke, there is recruitment of the neutrophil into the airways, and this neutrophil release this elastase, and this also is responsible for breaking down of elastin. Now, if there is adequate presence of this anti-elastase, then the effect of elastase will be nullified. So it is a protective factor. However, in certain individuals, there is deficiency of this anti-elastase, and the name is alpha-1 antitrypsin. So if this alpha-1 antitrypsin is deficient, then the same neutrophils will be able to cause more damage because this elastase is not being neutralized. Okay. Then oxidative stress, yes, it releases certain chemicals, interleukin 8, TNF alpha, which also cause macrophage activation, and it releases proteinases. Okay, so this is the hypothesis for the pathogenesis of COPD. Main, very important is cigarette smoke, which causes macrophage activation and epithelial cell activation. Then there is CD8 T cell recruitment. Then we have elastase anti-elastase hypothesis, important for genetic predisposition, and oxidative stress, which is very important especially in predisposed individuals. That means people who are smokers or they have this anti-elastase alpha-1 antitrypsin deficiency. Okay, now here I am talking mainly about the alveoli extracellular matrix damage, but this is also important for the inflammation in the airways. There also this ECM damage is going to take place. There will be chronic inflammation, that is recruitment of these macrophages, neutrophils, and hence there will be repair mechanisms also which will be started, which will ultimately lead to fibrosis. Okay, moving on to the next part, that is Because of this, what is the pathological features which occur in the various segments, that is the large airways, small airways and alveoli. And I told you that this small airway destruction is the hallmark of COPD. So just let me draw this. Say suppose this is the airways and here we have the alveoli. Lot of divisions will be there that you have to understand. Okay. So what are the changes which are going to take place? See, changes will occur inside also and outside also. So inside we have the lining epithelium is there, and in between the lining epithelium we have certain cells which are secreting mucus, that is the goblet cells. So you see there is mucus gland enlargement is going to there, so that that is going to secrete more mucus. That is happening in chronic bronchitis, cough with lot of sputum. So it is because of mucus gland enlargement. Then there is neutrophil influx also, and there is goblet cell hyperplasia. So both are going to release lot of mucus. Then we have squamous metaplasia. So the lining cells, there be certain changes which will predispose the person to development of lung cancer. Okay, so metaplasia is change in the quality of the cell. So that is squamous metaplasia which predisposes to cancer. Then there is also smooth muscle hypertrophy and bronchial hyperreactivity. So there is lining smooth muscle, right? So that also is going to hypertrophy, and increase in the reactivity of the bronchus is going to be there. Now this component is more in asthma. Yes, bronchial hyperreactivity is too much, but there is also some part of it happening in COPD. So what a normal individual, suppose they are exposed to pollutants, and a COPD person, when he is exposed to the pollutants, the reactivity is more in COPD patients. Okay, moving on to the small airways, again similar thing, goblet cell metaplasia is there. Goblet cell metaplasia, because you see that in a small airways there is club cells which secrete surfactant. These club cells are replaced by this goblet cells. Okay, so these club cells convert, we can say that, into goblet cells, and they also start releasing mucus. So there is deficiency of surfactant release as well. There is smooth muscle hypertrophy. There is luminal narrowing. So here the lumen actually narrows. Okay, and because of the chronic inflammation, there is fibrosis. So luminal narrowing occurs because of two things. One, goblet cells are releasing lot of mucus, and because of chronic inflammation, there is fibrosis. Then respiratory bronchiolitis, that is inflammation of the bronchioles are there. And I am telling you again and again that there is neutrophil infiltration that is going to cause elastin damage. Both neutrophils and macrophages are going to damage the elastin, thus making it as one mass. Okay, so that is the emphysema. Then moving on to alveoli. Alveoli, we have discussed that there will be development of emphysema, there will be destruction of the septa, so all the alveoli are going to become as one mass. Okay, this will decrease the surface area for gas exchange. Now this emphysema is of three types, either centrilobular, paralobular or paraseptal. So suppose this is the respiratory bronchial region, and here these are alveolar ducts and we have alveoli here. Okay, so this is the region where respiratory gas exchange takes place. We have respiratory bronchioles, alveolar ducts and the alveoli. Centrilobular emphysema mainly affects the respiratory bronchial region. So here this will all become as one mass, right? So there will be destruction of the septa and this is going to become as one mass. Paraseptal emphysema mainly affects this distal region where it is the alveoli mainly it is affected. So here it is becoming as one mass. On the other hand, paralobular or pan-acinar, there is two terms, paralobular or pan-acinar emphysema. Here it is the whole structure which will become as one mass. So it is affecting diffusely. Fourth one, there is another one where we have irregular emphysema. Okay, so that affects irregularly as the name suggests. Right. Now it is important to know this because it will be seen in chest x-ray, and based on that the treatment also depends, because in certain patients in emphysema there may be formation of bulla. Bulla is what? That all these alveoli will come together, so it will form one bulla which will be hyperinflated. So in certain patients this bullectomy is done, or sometimes more resection of the lung is required, that is known as lung volume reduction therapy. Because what happens, if this bulla enlarges, it is going to compress the remaining area as well, because this region is hyperinflated. Okay, so sometimes we need to remove this particular area from the lung, so that is known as lung volume reduction therapy. Now, if it is irregular emphysema which is spread throughout the lung, can it be done? No, it cannot be done. Right. In fact, this lung volume reduction therapy is most effective in centrilobular emphysema, in which there is emphysema developing in the upper lobe. Right. So, with this, let us move on to what will be the clinical presentation of the case. Just 2 minute summary I will do. That we have seen that COPD is emphysema, and there is chronic bronchitis and a small airway disease. And before it was that, okay, either there will be emphysema or chronic bronchitis. Now it is not like that. Now we say that in all patients of COPD we have mixed components. There will be some component of emphysema as well, and some component of chronic bronchitis also. Okay. However, there can be predominant presentation. That means it can be emphysema predominant or it can be chronic bronchitis predominant. So that we can determine from the case history. Okay. And we have seen about the pathogenesis. And what about the pathophysiology? See, there is destruction of the septa. So there is decrease in the gas exchange. Decrease in gas exchange will decrease the partial pressure of oxygen in blood. Okay, so that is going to lead to hypoxia. And there is hyperinflation of the lungs because expiration problem is there. So lungs are always like expanded. So because of this, basically ventilation is less. For ventilation, we want that it should expand and recoil. So that is needed. If it is chronically expanded and there is problem in the recoil or decrease in expiration, then there is decrease in ventilation. Okay. So because of this, there is ventilation perfusion mismatch as well. Okay. So with this, let us move on to the clinical features, what we are going to see. So in case, we will see chief complaints mainly as breathlessness, cough and sputum. Breathlessness, why? Because hypoxia is developing, so the person is going to be breathless, and because of the presence of chronic bronchitis, there will be cough and sputum as well. Now, whether the COPD is emphysema predominant or chronic bronchitis predominant, I mean which of them developed early, this case history will vary. Chronic bronchitis mainly has this cough and sputum developing first, so it will be present, say suppose since so many years, and slowly it will progress to development of breathlessness, and which also is going to develop or progress, like suppose initially the breathlessness will be while performing heavy tasks, right? Later on it may increase while walking or climbing stairs, then it may develop even while walking normally. The person may not keep up pace with his peers. On the other hand, in emphysema, initially breathlessness will develop. So the breathlessness will be present for so many years, and when there is exacerbations, that means when there is exposure to certain pollutants, then there will be exacerbations in which there will be presence of this cough and sputum. And slowly as the disease progresses, this breathlessness intensity is going to progress, and also this cough sputum is going to progress. Okay, so you have to remember in COPD, one is like chronic history and the chief complaints. Chief complaints may be mostly due to the exacerbations which have occurred. Exacerbation is basically increase in the intensity of the symptoms which were already present, right? So that is the chief complaint, exacerbations of breathlessness, cough and sputum with maybe dust exposure. Or there may be infection also. There can be bacterial infection, viral infection. So there might be presence of fever as well. Now, when you start taking history of presenting complaint, then you will come to know that how long this breathlessness or how long this cough and sputum might be present. So the person will tell that breathlessness was present since so many years, and the cough maybe it is recent, or maybe the breathlessness is present since 5 years, and since 2 years cough is present, and now it has increased in intensity, right? So when breathlessness is coming first, then you have to think about that maybe it is emphysema predominant. But yes, you have to keep in mind about bronchial asthma and interstitial lung disease as well, because this breathlessness can be present in interstitial lung disease as well. On the other hand, asthma, it will have episodic breathlessness and cough and wheezing episodes will be there. Okay, next is this presence of wheeze is very important, because wheeze is present when the person is exhaling. Wheeze is the abnormal sound which we hear when the person is exhaling. So in airway diseases, when there is obstruction, there is presence of wheeze. So it is a very important sign to differentiate whether it is a airway disease or it is a parenchymal or interstitial disease. Okay, so breathlessness with wheezing is a important history which you will get. Okay, then you have to talk about the progression of breathlessness, that which type of activities the person is able to do, which type of activities he was not able to do, and how it is progressing over time. So we will see that he will say that he was not able to do the exercises or work which require hand raising above the shoulder, but anything which cause the hand to be in front like that, he is able to perform those particular exercises. Okay, then you have to ask about the history of exacerbation frequency, how many times exacerbations have occurred, because that defines the severity of COPD. That has to be taken into account, because that will determine that how you are going to treat the patient as well, because then you will be giving drugs which will reduce the frequency of exacerbations, right? Plus, it has been seen that if exacerbation frequency is more, then the progression of disease is faster. Okay, so that's why we need to reduce the exacerbation frequency as well. So that is the natural history of the disease. If it is untreated, then there will be development of pulmonary hypertension as well, because you see I am telling you that there will be hypoxia, right? So there will be decrease in partial pressure of oxygen, gas exchange is affected, so decrease in partial pressure of oxygen in the pulmonary vessels will also occur. So this leads to pulmonary vasoconstriction. Okay, so there will be pulmonary vasoconstriction, and even though it is a protective response to prevent the ventilation perfusion mismatch. See, wherever oxygen is less, if the vessels there is constricted, then the blood will go to better ventilated areas, isn't it? So this is a protective response which works for some time, but later on, if pulmonary vascular constriction occurs everywhere, then it is going to increase the pressure in the pulmonary vessels, that is pulmonary hypertension, and this is ultimately going to lead to right ventricular failure. Okay, so this is the natural history how the disease is going to progress. Moving on to the next, that is personal history. Personal history, the person may be a smoker. High chances that person is a smoker, because 80 to 85% cases of COPD occur in smokers. Okay, and then you have to ask a history about occupational exposure as well. So we should know what the person's occupation is. So is he exposed to occupational dust somewhere? Then family history, very important if anybody else has suffered, because that will give you an indication whether there is alpha-1 antitrypsin deficiency. So that was about history. Now what you are going to see in general examination, the person will characteristically, you will see that he is sitting in hunched back position, and that is for facilitation of working of accessory muscles. So you see that work of breathing will increase in any respiratory disease. Work of breathing is going to increase, because whatever he is inhaling, that is not sufficient to cause normal partial pressure of oxygen. So there will be involvement of accessory muscles of respiration as well. So this position facilitates action of accessory muscles. Then in general examination, you have to note the signs whether the person is a smoker. You will see. Then build of the person. See, because of presence of chronic inflammation, the person will be cachectic and he might be very, very thin actually because of the presence of chronic inflammation. Because that is going to cause weight loss and the person's appetite will also be less. The person will have pursed lips breathing and increase in the respiratory rate. Since there is a breathlessness, there will be increase in the respiratory rate. Then, if there is carbon dioxide retention, see, we are telling that gas exchange is affected. So, oxygen will not be able to come into the pulmonary vessels, and if this condition is severe, then carbon dioxide diffusion may also be affected. Even though this carbon dioxide diffusion is affected much later, see, carbon dioxide diffusion is 20 times faster than that of the oxygen. So this comes late in disease. But if there is carbon dioxide retention, then we will get high volume pulse. Why? Because this carbon dioxide, increased partial pressure of carbon dioxide in blood vessels, that will lead to vasodilation of the blood vessels. And this vasodilation of the blood vessels, that is going to decrease the diastolic blood pressure. Okay, so we are getting increase in the pulse pressure that is greater than 60 millimeter mercury. So when you measure BP, we will see high systolic blood pressure but less diastolic blood pressure, and this leads to high volume pulse. Sometimes there is irregular pulse because of the presence of atrial tachycardia, multifocal atrial tachycardia, which is associated with COPD. Then, in case of exacerbations, there can be presence of pulsus paradoxus. Then there might be presence of cyanosis because the person is hypoxic. Hypoxia causes central cyanosis, right? So there will be presence of cyanosis in lips as well as nails. So you have to check for the mucosa of the mouth and also in the periphery. Clubbing will be absent. Okay, if clubbing is present, then you have to look for other causes of clubbing, that is presence of interstitial lung disease, or if it is a COPD patient and clubbing has developed, that means there is development of malignancy. In COPD patient per se, there will not be any clubbing. Edema, you have to see peripheral edema present or absent. In case right ventricular failure has developed because of the development of pulmonary hypertension, then there will be presence of edema. You have to see JVP. Yes, if right ventricular failure has developed, then right atrial pressure is going to increase and that is going to increase JVP as well. Okay, so these are the signs of presence of cor pulmonale, that is development of pulmonary hypertension and development of right heart failure because of lung disease, that is cor pulmonale. So you have to see the signs, that means the disease is in a very late stage where pulmonary hypertension has developed. So pulmonary hypertension doesn't develop very fast in case of COPD. However, if it is a long standing COPD, then we will have these signs as well. Tremors, you have to see. If there is carbon dioxide retention, then flapping tremors may be seen. And since he is a COPD patient, long-standing COPD, and if he is on beta-2 agonist, salbutamol, then there may be presence of fine tremors. Okay. Moving on to systemic examination, what you will see in respiratory system examination, in inspection, apical impulse may not be seen. Why? See, there is hyperinflation because the air is trapped. Okay. So, because the chest is filled with so much air that you will not be able to appreciate the presence of apical impulse, right? Then there may be presence of Hoover's sign, that is indrawing of intercostal spaces during inspiration. Normally, with inspiration, chest is moving outward, but in this case, what we are seeing, that intercostal spaces are moving inward. Why? See, because there is hyperinflation. Okay, so this is the diaphragm normally. In case of hyperinflation, diaphragm is flattened like this. So its attachment with the ribs, it is changed. Okay, so its contraction when it occurs, the diaphragmatic contraction, the pull of the ribs, the angle in which it is occurring, it is changed. So that's why instead of that outward movement, we see indrawing of intercostal spaces during inspiration. So that is also a sign of hyperinflation. Then we have fullness of supraclavicular fossa. So here we will see fullness, again a sign of hyperinflation. So you see, because of the presence of emphysema, so many signs of hyperinflation will be seen. That is, apical impulse will not be seen, Hoover's sign will be there, fullness of supraclavicular fossa will be seen. What will we see in palpation? Anteroposterior is to transverse diameter of the chest. We see the diameter, anteroposterior, transverse diameter, we calculate the ratio. Normal ratio is 3:5. Anteroposterior diameter is less, transverse diameter is more. In case of hyperinflation, the patient becomes barrel chested. Okay, so this diameter actually increases with a ratio of 1:1 because this anteroposterior diameter also increases. So again, this is a sign of hyperinflation, basically the air trapping in the lungs. So barrel shaped chest due to hyperinflation. Chest expansion also decreases. So you have to measure the amount of the chest expansion, ask the person to inhale and exhale. Okay, normal chest expansion is approximately 4 to 6 centimeter. Because the person is already, there is so much expansion of the chest and there is problem in exhalation, this chest expansion will be much less. Okay, chest expansion is decreased. Apex speed, because of the same reason, because of the hyperinflation, it will not be palpable. And there is something known as cricosternal distance, that is going to be decreased. So there is cricoid cartilage and there is a suprasternal notch. Normal distance is approximately 2 to 3 finger breadths. That is going to decrease because of the fullness. Okay. So you see there is so many signs of hyperinflation which we are seeing in inspection and palpation. Then what we will see in percussion? Percussion, we will see hyper resonant note because everywhere air is there. Okay, so there will be hyper resonant note and cardiac dullness will be obliterated. So there also there will be resonant note will be heard. Why? Again because of the trapping of the air. Liver dullness is pushed downward. Normally it is present in 5th to 6th intercostal space in right midclavicular line. And because of the hyperinflation, I told you diaphragm is pushed downward. So that is also going to push the liver downward. So this liver dullness, when you are percussing, the note you will hear much downwards. So liver dullness is pushed downward. What about auscultation? Auscultation, where there will be decrease in the breath sounds because ventilation is less. You might wonder that everywhere there is air. Yes, but ventilation is decreased and auscultation tells about the ventilation. Okay, so breath sounds is decreased. Quality of the breath sound is vesicular only and there will be presence of rhonchi. That is because of airway obstruction. Okay, so the person will give you history of breathlessness with wheeze, that expiratory sound you can hear, and this on auscultation also you will hear this rhonchi, again a sign of airway obstruction. And if pulmonary hypertension has developed, then this pulmonary valve, it is going to close later. So there will be splitting of S2, right? So these are the signs in auscultation. Moving on to investigations. What are the investigations? Again, based on what we have discussed, you see investigation, there is COPD questionnaire. That is to determine the severity of COPD because ultimately the treatment depends on the severity of COPD. What are the symptoms, how many exacerbations the person has got. Then blood counts. Hemoglobin, you will see it is that increased. Why? Because of the presence of chronic hypoxia, there is decrease in PO2. So this is going to lead to the production of erythropoietin from the kidneys. Okay, and this erythropoietin is leading to increase in production of RBCs. That is going to increase the hemoglobin levels. Okay, so increase in hemoglobin, increase in RBC count will be there because of chronic hypoxia. During exacerbations, yes, you have to get sputum culture and sensitivity to find out the organism and its sensitivity to antibiotics for the treatment of the exacerbation. Chest X-ray you will do to find out the signs of the hyperinflation and also presence of any bulla. Then these bulla actually can rupture. Okay, they can rupture, especially if they are near the pleura. Then this rupture, it is going to cause pneumothorax. Okay, so we have to look for signs of pneumothorax also in chest X-ray. So chest X-ray, we ask the person to hold the breath in expiration to detect this presence of pneumothorax. Okay. Then we have spirometry. Spirometry is the gold standard. Why? We will see the features. Actually, it is an obstructive lung disease. Okay. So in obstructive lung disease, we have FEV1 which decreases, and FEV1 by FVC ratio also decreases. Okay, and it is diagnosed based on this FEV1 FVC ratio. If this FEV1 FVC ratio is less than 0.7, then it is diagnostic of presence of obstructive lung disease, right? Then diffusing lung capacity also decreases, because I told you it is the gas exchange areas which are being affected. So if they are being affected, there will be decrease in the gas exchange. Then you have to do CT, especially high resolution CT, to rule out the presence of interstitial lung disease, or also to see the presence of interstitial lung disease along with COPD. Sometimes they can be associated. So HRCT has to be done. Then ABG, arterial blood gas analysis, to detect the presence of hypoxia and presence of carbon dioxide narcosis. Okay. Then other tests you have to do to rule out other diseases. Okay. So you have to do the analysis for allergic lung diseases. So I told you that bronchial asthma can be a cause, and sometimes they may be present together as well. Okay, so it is important that you rule out allergic features as well, right? So that was about investigations. Moving on to the diagnosis based on investigation, that is the spirometry, which I said is the gold standard. So we classify COPD into 4 stages depending on the severity. We have mild, moderate, severe and very severe stages. You see, first criteria, it is same in all, that is the presence of obstructive lung disease, that is FEV1 FVC ratio less than 0.7. So that is the diagnostic criteria. But severity is classified based on how much is FEV1. If FEV1 is greater than equal to 80% of predicted, it is mild disease. Greater than equal to 50% but less than 80%, it is moderate disease. Then 30 to 50%, then it is severe disease, and less than 30%, then it is very severe disease. So again, very important to know it to determine the management, how it will be managed. Okay. Moving on to the treatment part, which I am not going to discuss in detail. Fundamental here is that you have to manage the exacerbations, you have to reduce the frequency of the exacerbations, and if there is presence of chronic hypoxia, you have to treat that as well, because chronic hypoxia will lead ultimately to the organ failures, pulmonary hypertension, right ventricular failure and other organ failures. So that also you have to take care. That is the main fundamental of treatment. Okay. So for that, first is a smoking cessation, because you have to decrease the progression of the disease and also you have to reduce the frequency of the disease. So smoking cessation. Then depending on the severity, you have to treat. So you have to give the bronchodilators, because we are telling that airway obstruction is the main problem. Main problem is in expiration, right? So that has to be done by muscarinic antagonist. Okay, so there is something known as short-acting muscarinic antagonist, long-acting muscarinic antagonist and beta agonist. So there are short-acting beta agonists and long-acting beta agonists. These are the bronchodilators. Actually, these short-acting beta agonists, they are the ones which reduce the symptoms. So acutely they are going to reduce the symptoms. But for decreasing the exacerbation frequency, it is the long-acting muscarinic antagonist and the corticosteroids. Okay, long-acting muscarinic antagonist, long-acting beta agonist and the corticosteroids are used to decrease the frequency of the exacerbation. Then obviously antibiotics you have to give for the treatment of this particular exacerbation depending on the results of sputum culture and sensitivity. Then to treat hypoxia, long-term oxygen therapy has been found to be beneficial. In fact, there are proper indications for long-term oxygen therapy and lung volume reduction therapy. For example, long-term oxygen therapy has to be given if oxygen saturation is less than 88%. And even if it is not less than 88%, but there is development of pulmonary hypertension with right heart failure, or there is presence of polycythemia, then long-term oxygen therapy has to be started. Similarly, there are indications for lung volume reduction surgery, which I told you earlier also, that if it is diffuse emphysema, then we cannot do lung volume reduction therapy. However, if there is a localized emphysema, especially in upper lobe, or there is presence of a bulla, then bulectomy can be done, lung volume reduction surgery can be done, so that there is proper functioning of the lung which is remaining. Then One more very important thing, that for such patients, vaccination for influenza and pneumococcal vaccine is recommended. So that was all about the fundamentals of case of COPD. I hope you understood the physiological basis and the pathophysiology of COPD. Thanks for watching the video. If you liked it, do press the like button, share the video with others, and don't forget to subscribe to the channel Physiology Open.